Top Med Talk.
Welcome to EBPOM 2018. It is day 2 of our meeting this week, and we are in London celebrating 20 years of evidence-based perioperative medicine, as well as 70 years for the NHS. So it's wonderful. Woo. It's been a great meeting so far. Lots of really great sessions. We're getting ready to go into our last session of the day, and we're going to be talking about pain, and we have 2 very special guests with us. I guess first I should introduce myself, though. I'm Desiree Chappell, host of Top Med Talk, and I'm joined here with my co-host today, Vicki Morton, who is one of our friends for Top Med Talk. Hey, Vicki.
Hello, Desiree.
And our 2 very special guests that we have. One is Padma Gulur. She has been here with us before at EBPOM USA. Thanks for coming back, Padma. She's the Professor of Anesthesia and the Executive Vice-Chair at Duke University. And we have Natasha Curran. She is a consultant in pain medicine and anesthesia at the University College Hospital and the medical director of the Health Innovation Network. Ladies, thank you so much for joining us. We're going to be pressed for time, but we're going to have some conversation and talk a little bit about pain control for the perioperative patient and how that works, especially with chronic pain patients. So, Natasha, I'm going to start with you. Can you tell us a little bit about what it is that you're doing right now with pain patients?
Yeah, certainly. Hi, Desiree.
Hi.
Hi, everyone else. I think one of the most important things is to identify the people who are at risk. So at risk of potentially having lots of pain post-operatively, or at risk of other things like opioid addiction. So we need to identify these people pre-operatively, not just on the day of surgery. So if we can have mechanisms that we can do that, that's one of the things that I'm looking at the moment. So in the system, before a patient comes to see a surgeon or after they've seen a surgeon, when the decision to have surgery is made, and also what things might be obvious things that we can say that if patients are on these type of medications like gabapentin, pregabalin, any of the opioids, there's probably a high chance that those patients are going to need a bit more input perioperatively, and we'd like to be able to make a plan with those patients so that their outcomes, their length of stay, all of those things are better.
Yeah. Padma, so this is kind of what you do, right, in the past clinics. Can you expand on that?
Sure, absolutely. We do similarly look to optimize patients preoperatively, and also for pain, we continue to follow them for up to 90 days after surgery, because there's 2 identified gaps currently in the way we take care of these patients. One is the lack of optimization and how they present to surgery. There's a lot of evidence and data that supports that there's more that can be done before these patients have a stressful surgical experience per se. But the other gap that's often overlooked is, while we do a great job with them for the intraoperative and postoperative period in the hospital, we get them all teed up, there is another cliff drop when they get discharged from the hospital, because there's a transition of care element over there that is not usually, easy to bridge with the way things are currently, because patients actually enter into what we are calling a subacute period. So, they're done with the acute period, they're really not ready for a more outpatient or chronic care directly without getting further support in a subacute setting. And that's what this clinic, what we've started at Duke, is meant to help, which is from decision to surgery. As soon as you've decided that you're going to do surgery on this patient, you can send this patient to this clinic if they have any features of currently experiencing uncontrolled pain, being in chronic pain, or on high-dose opioids, but also patients who may be at risk for post-operative complications like Natasha just mentioned, which is persistent pain, developing chronic pain eventually, or developing complications from the therapies used to treat pain, such as addiction, dependence, and other issues like that. You may well ask, well, how do you do that? How do you identify these patients? We're fortunate enough to have a bit of a head start with that, in the sense that our records allow us to identify these patients currently, and we allow the surgeons as well to make a decision on sending these patients through. We run them through some screens, simple screens that don't impact workflow immensely. And if they come out as positive, which is likely to have a poor outcome, then they are optimized in our clinic before surgery. Sometimes, in fact, we've had to postpone surgery in order to make that happen, to get enough time to do it. But most times we are able to actually keep up with the surgical timeline.
So I would like to ask both of you a question. You talk about the pre-op optimization and then following them for 90 days. And obviously, when we talk about enhanced recovery, I don't think it's always our 100% goal to have an opioid-free surgery. We want patients to be comfortable, but we do sometimes have those patients that go through and they are completely opioid free, or maybe they received a little fentanyl intraoperatively and postoperatively they've received nothing other than their multimodal analgesias, yet they are going home with 30 of oxycodone. How do you address that with your institutions?
I can speak to our experience here at Duke. You are so right. We talk about opioid-free anesthesia, but we truly just mean the intraoperative and likely the immediate, if we're lucky, postoperative period. For the most part, though, patients seem to go home on similar prescriptions. That's actually a factor of the workload and the workflow that has traditionally been in place. And you have all these templates and guidelines which help in many ways with workflow, but can also, in this case, actually have unintended consequences where everyone gets the same prescription on their way out the door and the wrong message. So what we have done is actually surveyed the patients to create more personalized discharge plans for them on how much they need or if they need anything. And the templates have been changed so that the patient can only leave on that particular amount of medication.
Natasha, I have a question for you. Does that happen in the UK? That you do this opioid sparing type of surgery and then they go home with a ton of narcotics?
It definitely happens. The anaesthetist might be quite on the ball for the very immediate post-operative period, but then what might happen on the ward afterwards and prior to discharge, there may be a disconnect there. And also that there's definitely been a problem where there's not been, I personally set the expectation with individual patients about how long they should be on an opioid for, and saying that there may be some variation on that, but so that they know that they should be coming off it. And if you have a very junior doctor discharging them, that might not be written on a discharge summary to the general practitioner or the family doctor who's looking after the patient after discharge. And the other thing is that about 50% of the patients that come that are discharged on an opioid out of hospital, that's a new prescription, and the information that's then given to the family doctor about how long that should be continued is very, very poor. So I think that is a real gap and an opportunity for us to impact on population health. Really,
it's a gap in the United States as well. It's something that I think we've fallen down on. We are not engaging our primary care partners in this whole process. We've tried to in where I live, and we've had small bits of engagement, but I think that we need to be better at helping educate them what we're doing in a perioperative phase, because it doesn't end when they walk out that door.
Absolutely.
It ends months and months down the line.
So as physicians, this is one question I've had from an international perspective, maybe you can answer this. Is the curriculum for doctors changing? I mean, the opioid crisis has now been around, and we've been talking about this for a couple of years now, and I would imagine that because of the epidemic status of it, that it's becoming, something that needs to be talked about in the education for doctors, nurses, everyone else. Is that happening here in the UK?
I know that in the UK, traditionally we had very poor amounts of time spent on pain, full stop, in curriculum. Actually, the vets and dentists got more time than the doctors do or medical students did. I think that is changing, and I really think that it's important that the societal knowledge is greater. So I welcome all the media attention to the opioids and stuff at the moment, because we shouldn't just be getting this information through our doctors and healthcare professionals. It should be something that is the knowledge of our society is better. It should be better about these things, I feel.
I completely agree with you.
Right. In the U.S., absolutely. More and more now, this awareness and the heightened awareness, I should say, has had a very positive impact in that regard, because medical school curriculums are incorporating and actually expanding the amount of pain management education that's being provided at that level. Residencies, fellowships, all the training programs that we have are actually improving it. Share a bit of good news, to show you how much education, just awareness, can have a positive consequence. The amount of opioid produced, as you know, is controlled in the world and in the United States as well. And we had been on a logarithmic increase trajectory since 2000 and early 2000, to where by 2014 and 15 we were at almost 4 times what we were producing, a decade or so before. And that trajectory didn't look like it was going to get stopped in any way. 2017 and 2018 are the first 2 years that we've had a huge decrease, actually a significant decrease in the amount of opioid produced, because the demand has gone down. In fact, we're at about 2012 levels right now.
I'd like to share another piece of good news, is that actually our national perioperative quality improvement program, as one of its 5 stated priorities, that has number 4 is individualized pain management. And I think that I've been in pain medicine or interested in it for many years now, and it wasn't so seen as such a mainstream event, and now I think it is, and that I really welcome that it being seen as a true sort of theme of perioperative medicine means that many more doctors, and the more junior ones particularly as well, have an awareness about the importance of pain medicine and also how it can impact on outcomes and the potential pitfalls as well. So I think that whilst it may not be as kind of impacting on curriculums as much, I think that there's a greater sense of its importance, which can only be good.
Well, and I hope that actually we can extend this to non-physician providers, nurses, advanced practice nurses, those people that are kind of on the ground level at bedside, choosing between the narcotic or, Tylenol and NSAIDs every 3 hours.
And re-educating their patients.
Yeah.
You don't want to refuse this acetaminophen because it's actually helping you, and we don't want to give you oxycodone.
Sorry to interrupt. Going beyond medicines as well. That's one of the big drives I've had in our hospital in the last 2 years has been pain education, which is non-pharmacological as well.
Right,
absolutely.
Paying attention to the distress, which of course nurses traditionally have always done. They pay attention to the distress, not necessarily with medicine that will resolve it, but you know yourself. If someone pays attention to you, if you're in pain, if you're fearful, that has an impact, even if you don't give them a medicine that will take away the pain, because
simple acknowledgement.
Makes everyone feel better.
Yeah, well, that's great.
I do feel, if I could just make another comment, I do feel that we need to be better about educating our nurses. I don't know about you, Desiree, in your practice. I know when I'm with the nurses in my institution in 6 hospitals, a lot of them have been there for quite some time. They've become accustomed to their patients not being in pain, and even though they hear it, their first inclination is to still give that pain medication with a pain score of 2 because they want it to be 0. And I think that somehow we need to do better at educating.
Well, we were always taught, it's better to be on top of your pain than behind the curve because it takes so long to catch up. And I mean, I've said it myself as a nurse, and so you instruct your patients, we need to give you these Norcos every 4 to 6 hours because we don't want you to have pain.
And we're still sending the same message, don't get it wrong. We want them to control pain. We're not looking for a nation in pain again.
No.
But what we're saying, though, is that you don't need to use the Norco. There are other agents that can be used, and in fact, probably used in earlier stages in a more scheduled way, so that the patient never hits those kind of crisis points to need Norco, per se.
Well, I think that's great to end on, ladies. Thank you so much. We know we got to get you back in there to give your presentations. Thank you for joining us at Top Med Talk here at EBPOM 2018.
Thank you.
Thank you.
Top Med Talk